Does ERCP with minor papillotomy reduce the risk of recurrent pancreatitis? What are the prescribing patterns of CNS-active medications in older adults with normal cognition, cognitive impairment, and dementia? How have exemptions for childhood vaccination changed since 2010? This and much more on today's JAMA Editor's Summary. Hello and welcome to our listeners all around the world. Today is Friday, January 16th, 2026. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hi, Preeti. Let's get started.
Hi, Linda. Pancreatic duct obstruction, including the congenital variant pancreas divisum, has historically been treated with ERCP and minor papillotomy, despite limited evidence. The SHARP trial was designed to determine whether ERCP with minor papillotomy reduces the risk of recurrent pancreatitis. Dr. Cote and colleagues conducted a multi-center double-blind, sham-controlled randomized clinical trial. Participants included 148 adults with a mean age of 54 years, 68% of whom were female, with 2 or more episodes of unexplained acute pancreatitis and pancreas divisum. They were enrolled across 21 centers in the U.S. and Canada. The primary outcome was development of acute pancreatitis, more than 30 days post-randomization. They also assessed several secondary outcomes like the frequency of pancreatitis episodes, the development of chronic calcific pancreatitis, diabetes, and exocrine pancreatic dysfunction. The authors found that ERCP with minor papillotomy did not significantly reduce risk of future acute pancreatitis compared with the sham procedure. Acute pancreatitis occurred in 34.7% of those participants undergoing ERCP with minor papillotomy, compared with 43.8% of those assigned to the sham procedure. In terms of secondary outcomes, no significant differences were observed in the frequency of pancreatitis episodes, development of acute calcific pancreatitis, diabetes, or exocrine pancreatic dysfunction. However, the adverse event of acute pancreatitis within 30 days was higher in the minor papillotomy group, 14.7% compared with 8.2% in the sham group. The investigators conclude that ERCP with minor papillotomy does not lower the risk of recurrent acute pancreatitis or related complications among patients with pancreas divisum, suggesting that this intervention should be reconsidered for this patient population.
The editorial by Drs. Rumai and Muthusamy reiterate that the SHARP trial found that ERCP with minor papillotomy does not reduce recurrent pancreatitis or related complications in these patients, challenging long-standing assumptions behind this intervention. High-quality evidence suggests conservative management may be safer and that routine endoscopic intervention should be avoided, highlighting the need for new research to uncover better treatments for idiopathic acute recurrent pancreatitis. Preeti, let's turn to this week's research letters.
Sure, Linda. Older adults, especially those with cognitive impairment, are at a higher risk of harm from central nervous system active medications. Yet these drugs, like benzodiazepines, antipsychotics, and others, are still frequently prescribed, despite long-standing guidelines recommending against their routine use. A research letter from Dr. Yang and colleagues analyzed national prescribing patterns from 2013 to 2021 using the Health and Retirement Study data linked to Medicare fee-for-service claims, focusing on 5 high-risk CNS-active drug classes and whether prescriptions had documented clinical indications. They found that the prescribing of potentially inappropriate CNS-active drugs declined from about 20% to 16% during the study period, with the biggest drops seen in benzodiazepines and sleep medications. However, people with cognitive impairment remained more likely to receive these drugs, and in 2021, more than 2/3 of these prescriptions had no documented clinical indication, highlighting opportunities to further improve safe prescribing for older adults.
A separate research letter by Mustafa Fatah and colleagues reports on trends in U.S. county-level childhood vaccination exemptions. Exemptions, especially for non-medical reasons, can create pockets of under-vaccination, increasing the risk for outbreaks of preventable disease. In this study, researchers collected and analyzed county-level data on medical and non-medical, for example, personal belief or religious exemption, to childhood vaccinations, primarily for kindergartners from 2010 to 2024, using information from 45 states and D.C. Non-medical exemptions rose steadily nationwide, especially after 2020, with the median county rate climbing from 0.6% in 2010 to 2011 to 3.1% in 2023 to 2024, while medical exemptions stayed about the same. Certain counties and states had much higher rates, and states that eliminated non-medical exemptions saw declines. The results raise concerns that increasing non-medical exemptions, most of which are concentrated in a fraction of U.S. counties, could contribute to a resurgence of vaccine-preventable disease.
JAMA also published some interesting viewpoints. Doctors Nakate and Berliand argue that rising education costs, stagnant physician incomes, changes in loan repayment, and lengthy training make becoming a doctor increasingly difficult and financially risky. Without reforms to restore affordability, a career in medicine may become inaccessible to many, worsening physician shortages and reducing workforce diversity. Opioid settlement funds totaling $57 billion offer a major opportunity to save lives if used for evidence-based interventions like harm reduction and medication-assisted treatment, but much of the current spending is fragmented or supports ineffective programs. Doctors Etkin and Robertson argue that states and localities should prioritize independent, expert-managed funds and proven strategies to ensure that these resources truly address the opioid crisis and its root causes.
Sophie Dilek and colleagues contributed a special communication in the JAMA Clinical Reviews and Education section. They conducted a qualitative analysis of the FDA's regulation of mifepristone, a drug with multiple uses including medical abortion. Mifepristone has evolved through several key decisions from 2011 to 2023, including implementation of safety programs and changes in response to the COVID-19 pandemic. Throughout this period, FDA scientists consistently found mifepristone to be safe. The authors found that regulatory decisions were largely based on scientific evidence rather than political influence. The FDA's cautious, evidence-based approach has guided mifepristone oversight, even amid changing legal challenges.
In their editorial for this article, Drs. Ramachandran and Morton note that political pressure has prompted a new review of the FDA's safety rules for mifepristone, despite prior science-based decisions. They warn that political influence and limited transparency could affect future regulation and urge the FDA to maintain scientific rigor and openness to preserve public trust. Don't miss the related podcast conversation. Dr. Alexander from Johns Hopkins, an author of this special communication, discusses more with JAMA Deputy Editor Dr. Joseph Ross. Here's a clip from their conversation.
Yeah, well, I already mentioned that the regulation of the product has evolved over time, and I think that these documents provide a really important window through which to understand what is normally a very opaque process for researchers and drug safety experts such as myself that are interested in actually how regulation is taking place. I think the first major theme is that there were very consistent findings on the safety of this product. The FDA has monitored this over years and years and years based on spontaneous adverse event drug reports, based on clinical studies, based on the published literature, and based on information submitted by professional organizations and advocacy groups. And the documents that we reviewed are quite clear regarding repeated regulatory findings that mifepristone safety is well characterized, that spontaneous adverse events or that harms from the drug that are serious are rare and that best practice guidelines suitably minimize major risks.
The latest clinical review is about a 32-year-old patient with fever, rash, and dizziness. A quick hint, the patient lives in the upper Midwest. Post-intensive care syndrome, or PICS, a condition affecting over half of ICU survivors, causes long-lasting physical, cognitive, and mental health problems that can impact daily life and independence. Early assessments after discharge and individualized treatments such as rehabilitation, psychological support, and coordinated follow-up care are important for managing and reducing these impairments. Learn more by reading the JAMA Insights on this topic by Dr. Butcher, and check out a new JAMA film that features perspectives from patients, researchers, and clinicians.
Patients can learn about type 2 diabetes, including symptoms, diagnosis, treatment options, and prevention tips in this easy-to-understand JAMA patient page. The article highlights key risk factors, screening recommendations, and lifestyle changes that help manage and prevent this common condition.
Retinal imaging is emerging as a valuable tool for insights into human health. Dr. Lee joins JAMA and JAMA Plus AI Associate Editor Dr. Yulin Schwen on the JAMA Plus AI Conversations podcast to discuss how AI-powered imaging detects early disease signs, utilizes extensive data, and transforms ophthalmology care.
There's also been a lot of rapidly developing medical news. Our outstanding JAMA Medical News team stays on top of it all and gets you the latest articles in clinical medicine, biomedical research, public health, and health policy. Find it all at JAMAmedicalnews.com or click on the link in this episode's show notes. And the JAMA Medical News Summary Podcast is now weekly, publishing every Friday. Search for JAMA Medical News wherever you listen to podcasts.
Thanks, Preeti, and thank you to our listeners for tuning in to hear what's new at JAMA. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Daniel Morrow, Shelley Steffens, and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.